Right now, while you are sitting here, a decision is being made somewhere in this country that will change someone's life forever. Not a disease, not a diagnosis, a surgery. And the person sitting in that office has no idea what they are actually agreeing to. 99% of patients over 60 sign the consent form without asking a single one of the questions that could protect them. They trust the recommendation. They trust the institution. And some of them come out the other side permanently changed. Not better, changed. A man walked into a hospital with back pain. He left unable to walk at all. A woman survived open heart surgery but lost 6 months of her life to complications nobody warned her about. These are not rare stories. They are the stories the brochures leave out. Here is what I want you to understand before going any further. The older your body is, the harder it fights just to survive an operation. Not the disease, the operation itself. And that distinction, that one sentence, is going to matter enormously in the next 30 minutes. What country are you watching from right now? Drop it in the comments. I want to know who needs this information most. I have been practicing medicine for over 2 decades. I have sat on both sides of that surgical table. And what I am about to share with you today, I have never seen explained clearly in a doctor's office, because the appointments are too short, because the paperwork is already on the desk, and because nobody in a 7-minute consultation is going to walk you through the 5 surgeries that carry hidden risks most patients over 60 are never warned about. Before going further, a quick note. Everything I share today is based on published research and clinical experience. But your situation is unique. Please always have a full conversation with your own doctor before making any medical decision. With that said, let us begin. Now, I need to ask you something first. If you take a brand new car and a car with 200,000 miles on it, and you put them both through the exact same stress test, do you expect the same result? Of course not. And yet for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same surgical protocols, same recovery timelines, same expectations. That is changing, but not fast enough. Here's what happens inside an older body when it goes under general anesthesia. The heart works harder. The lungs take longer to clear the anesthetic. The kidneys slow down. And the brain, this is the one that surprises people, becomes temporarily disoriented in ways that can last weeks, sometimes months. Doctors have a name for it: postoperative cognitive dysfunction. In patients over 70, it happens far more often than anyone admits in those consent forms. Now, age alone is not a reason to avoid surgery. I have seen 80-year-olds bounce back faster than some 50-year-olds. What matters is not the number. What matters is frailty. That is a medical term. It means the body's reserve has dropped below a critical threshold. And here is what the research shows. Roughly 40% of people over 75 show signs of frailty. That number climbs to nearly 60% over 85. So here is the real question worth asking. It is not whether someone can survive the operation. It is whether they can survive the recovery. Those are 2 very different things. Now, I promised you 5 surgeries. And I want to be honest about something before I reveal the most important one, number 1 on this list. It is the one that catches families completely off guard. The one nobody talks about during the consultation. I am going to save that for later in this video because you need to understand the full picture first. Stick with me. It is worth it. Let us start with surgery number 2, because this one affects more people over 60 than almost any other operation in America: open heart surgery in patients who have become frail. Coronary artery bypass surgery is one of the most common major procedures performed on older adults. The basic idea is simple. The arteries are blocked. Blood flow gets rerouted. And for the right patient, in the right condition, it works beautifully. But here is what the brochure does not show you. Open heart surgery requires stopping your heart completely. You are placed on a bypass machine, a mechanical device that takes over the work of your heart and lungs while the surgeon operates. For a 60-year-old in strong health, that is manageable. For a 78-year-old with reduced kidney function, mild cognitive decline, and 3 other health conditions, that bypass machine is a simultaneous assault on every major organ in the body. A study published in the Journal of Cardiac Surgery found that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged confusion, extended time on a ventilator. And This is the number that stops people cold. Up to 15% of high-risk elderly patients do not survive the first 30 days after this surgery. 15%. Let that sink in. Now, does this mean you refuse heart surgery? Absolutely not. Heart surgery saves lives every single day. What it means is that you ask one specific question. You look your surgeon in the eye and you say, "Am I a candidate for a less invasive approach?" Because in many cases today, there is one. It is called TAVR, transcatheter aortic valve replacement, a catheter-based procedure. No stopped heart, no open chest. The recovery is measured in days, not months. And for patients who qualify, the outcomes are comparable. That one question, "Am I a candidate for a less invasive approach?" could change everything. But here is where it gets more complicated, because the system does not always volunteer that question. The system often presents what it is most experienced with, and that is not necessarily what is best for your specific body. This is not about blaming your surgeon. Your surgeon may be extraordinary. This is about a structure, a set of guidelines, many of which were written using data from younger, healthier patients. Your job, and I say this with complete respect, is to be an informed participant in your own care. Sandra is 67, a retired postal worker from Virginia who spent 30 years on her feet delivering mail in every kind of weather. When she came to see me, she had already been told she needed open heart surgery for a blocked artery. She had already signed the preliminary paperwork. She was scared, but she trusted the recommendation. And then she asked one question: what are my other options? The answer to that question changed her entire path. But I want to tell you what happened next a little later, because what I found when I looked more closely at her full picture, that is the part of her story that matters most. Stay with me. Surgery number 3, aggressive spinal surgery. Here is something I want you to hear clearly. Some spinal surgeries are absolutely necessary. No debate. A spinal cord being actively compressed, causing loss of bladder control or threatening paralysis, needs immediate surgical intervention. That is not what I am talking about today. I am talking about elective spinal fusion for chronic back pain in patients over 60. And the evidence here is genuinely troubling. Back pain in your 60s and 70s is nearly universal. I do not know a single patient over 70 who has not mentioned their back at some point. And the solution that gets offered more and more frequently is spinal fusion, sometimes multi-level, sometimes with hardware inserted at multiple points along the spine. Now, a major study published in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. 40%. And the most common complications were not minor: blood clots, infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fused section start breaking down because the mechanics of the entire spine have been permanently altered. One section holds rigid, the rest absorbs the price. But here is what frustrates me most about this conversation: the pain relief. Studies show that for many elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than physical therapy combined with targeted injections. No better, but with dramatically higher risk. I have a colleague, a spine surgeon with exceptional training, who once said to me something I have never forgotten. Sometimes the best operation is the one you do not do. Now, I know what you are thinking. My doctor told me surgery is my only option. If that sounds familiar, drop a YES in the comments. I want to know how many of you have heard those exact words, because you deserve to know that is almost never true. Surgery number 4, major cancer surgery in frail elderly patients. This one is the hardest to talk about, because when someone hears the word cancer, the instinct is immediate and powerful. Cut it out, remove it, get rid of it, and I understand that completely. But here is what 20+ years in medicine has taught me. The goal of treatment is not just to remove the tumor. The goal is to give you more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient does the opposite. Let me give you a real example. Pancreatic cancer surgery, called the Whipple procedure, is one of the most complex operations in medicine. The surgeon removes the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. The procedure itself can take 6 to 10 hours. In a younger, healthy patient, it can be life-saving. In an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed. The tumor is gone, and the patient still passes away within weeks, not from the cancer, but from the surgical complications, from the operation itself. This is called futile surgery, and it is more common than anyone in medicine wants to acknowledge publicly. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent resection experienced what researchers call failure to rescue. A complication occurred that the weakened body simply could not survive. Nearly 1 in 5. So what is the conversation worth having? Ask your oncologist this, and ask it directly. If I do not operate, what does watchful waiting, targeted therapy, or radiation look like for someone my age and health status? That question opens a door that many patients never even know exists. Surgery number 5. Elective joint replacement in patients with multiple serious conditions. I want to be completely clear here because I do not want to frighten anyone away from a procedure that genuinely transforms lives. Hip and knee replacements are among the most successful surgeries ever developed. For the right patient, a new hip is remarkable. People go from barely walking to playing with their grandchildren. But the word elective means planned. You have time to think, time to prepare, and crucially, time to ask whether this is the right moment for your specific body. Because in patients over 75 with 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, significant obesity, elective joint replacement carries meaningfully elevated risk. Blood clots are the biggest danger. Deep vein thrombosis, clots forming in the legs, can travel to the lungs and become life-threatening. In elderly patients with reduced circulation, this risk is substantially higher than in younger patients. Add post-operative pneumonia from limited movement. Add hospital-acquired infections. Add the extended recovery that a frailer body simply takes longer to complete. And the picture becomes far more complex than the 30-second description in the surgeon's office. The question is not, should I ever have this surgery? The question is my body in the best possible condition right now? Because optimizing blood pressure, blood sugar, cardiovascular health, and even muscle strength before an elective surgery can reduce complication rates dramatically. Some institutions now require a formal preparation program before scheduling these operations for higher-risk patients. Most people have never even heard that word, prehabilitation. Has your doctor ever mentioned it? Drop a comment below. I want to know. Now. Back to Sandra. When she asked her doctor about other options and actually pushed for an answer, she discovered something that changed everything: her frailty score. A formal assessment that measures a person's overall reserve, their ability to recover from a significant physical stress. Nobody had calculated it before recommending the surgery. When she came in and I ran that assessment, Sandra was in the moderate frailty range, not severely frail, but not the profile of a patient who would sail through open heart surgery and be back to herself in 6 weeks. Her kidneys were not at full function. Her cognitive baseline showed some early changes, and 3 of her medications interacted with the anesthetic in ways that needed careful management. None of that was in the consent form conversation. What came next, I want to tell you in a moment, because Sandra's story is not just about avoiding surgery. It is about what happened instead, and the results surprised even me. Now, if you are still with me, here is the moment I promised you at the beginning. Surgery number 1, the one that catches people off guard, the one nobody discusses during the consultation, the one I saved for here, because without everything you just learned about frailty and surgical risk, it would not make complete sense. Surgery number 1 is emergency abdominal surgery. And I want to acknowledge right away, this one is different from the others. You do not choose emergency surgery. It chooses you. A perforated bowel, a ruptured appendix, internal bleeding that cannot wait for a calm conversation in a doctor's office. But here's exactly why it belongs at the top of this list. Knowing the risks in advance, before an emergency happens, changes how families make decisions in those terrifying moments when time does not allow for careful thought. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of medicine. The research shows 30 to 50% in the most severe cases, not because surgeons are unskilled, because an elderly body under sudden trauma is fighting on too many fronts simultaneously. The liver, kidneys, heart, and lungs are all impacted at once. And the inflammatory response that a younger body controls within days can spiral in an older body into something called systemic inflammatory response syndrome. When multiple organs begin shutting down in sequence, it is as serious as it sounds. So what can you actually do with this information? Two things. First, do not ignore abdominal symptoms, persistent pain, bloating, significant changes in bowel habits in someone over 60. These deserve prompt medical attention. Catching problems before they become emergencies, that habit alone can change everything. Second, have the conversation with your family now, not in a hospital corridor at midnight. Now. What are your wishes if emergency surgery is the only option? What does quality of life mean to you? These conversations are not morbid. They are one of the most loving things you can do for the people who will be standing in that corridor. Now, let me give you something practical, because information without action is just anxiety. And that is the last thing I want for you. Before any major surgery, planned or recommended, there are 4 questions every patient over 60 should be asking. Write these down. Question 1. What happens if I do not have this surgery? A good surgeon will give you an honest answer. If that answer is nothing urgent changes in the next 6 to 12 months, you have time. Time to think. Time to get a second opinion. Time to prepare your body. Question 2. Is there a less invasive alternative? Medicine has changed dramatically in the last 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions. Options that did not exist a decade ago are now available at most major medical centers. If none of those came up in your consultation, it does not mean they do not exist. Question 3. What does recovery realistically look like for someone my age and my specific health profile? Not the average patient. You. Your heart, your kidneys, your current medications, your living situation. The answer should be specific, not generic. Question 4. This is the one most people never ask. What is your personal complication rate for this procedure in patients over 70? Surgeons track this. They know their numbers. A confident, honest surgeon will tell you. If that question makes the room tense, that tension is information. Now, if you find this helpful, hit like right now. It costs you nothing. But it tells the algorithm that this information matters, and it helps get it in front of the people who need it most. Let me talk about something almost nobody receives before surgery, because it can change your odds more than almost anything that happens in the operating room. Prehabilitation, training for an event. Because that is exactly what surgery is. Your body is about to run a full marathon while you are unconscious, and the stronger the body you bring to that starting line, the better the outcome on the other side. In the 2 to 4 weeks before surgery, here is what the research from Johns Hopkins University and other major institutions consistently shows matters most. First, protein. Your body rebuilds tissue using protein, and most adults over 60 walk around quietly under-eating it. Before a planned surgery, increase your protein intake. Eggs, fish, chicken, Greek yogurt. These are the raw materials your body will need to heal. Second, walk every single day, even just around the block. The stronger your legs and your lungs going into surgery, the faster you are up and moving on the other side. And getting up and moving is exactly what prevents the blood clots and the pneumonia I mentioned earlier. Third, if you smoke, stopping even 2 weeks before surgery measurably lowers your risk of wound complications and lung complications. 2 weeks. That is not a lifetime commitment. That is 14 days. Now, Sandra. 6 weeks after that first conversation, she had not had surgery. She had started a structured preparation program, better nutrition, daily walks, medication adjustments under careful supervision. And I pursued an alternative intervention for her arterial blockage, a catheter-based approach that never required stopping her heart. The procedure took 2.5 hours. She was home the following day. 3 months later, she sent me a photograph. She is standing in front of the mailboxes on her old route in Virginia, the same route she walked for 30 years. She is smiling. Her daughter is standing next to her. She wrote 3 words at the bottom. I asked questions. That is it. That is the whole story. Now, before surgery of any kind, there is one more conversation almost nobody has. The conversation with the anesthesiologist, not after you are on the table. Before. Days or even weeks before. Remember the brain fog I mentioned at the beginning? Post-operative cognitive dysfunction. There are real, practical steps that reduce the likelihood of it. Ask for a preoperative anesthesia consultation. Bring a complete list of every medication and every supplement you take. And I mean everything, including the fish oil and the herbal sleep aid, because some of them interact with anesthesia in ways that genuinely surprise people. Ask whether a regional or spinal anesthetic, where only the surgical area is numbed rather than putting your whole brain under, is possible for your procedure. For many hip and knee operations, it is. And for an older brain, it is often significantly gentler. And here is something that sounds almost too simple to matter. If you wear hearing aids or glasses, ask to keep them with you right up until the moment you go under, and to have them back on the moment you wake up. Patients who can see and hear clearly when they regain consciousness experience hospital-related confusion far less often. The research on this is consistent, and it costs nothing. Now let me give you something most patients never hear, because it changes how you read a surgical recommendation. Over the years, I have learned that the way a surgery gets presented to you tells you almost as much as the surgery itself, and there are specific warning signs. When you hear them, you slow down. The first red flag is speed. You are being rushed. You need to get on the schedule as soon as possible. If you are bleeding internally, yes, move quickly. But for a planned elective operation, real urgency is rare. A knee that has hurt for 10 years does not have to be replaced this month. If the pressure to decide feels intense and immediate, ask why right now. The answer almost never has to do with your body. The second red flag is a single path. You leave the consultation with exactly one option: surgery, and no mention of alternatives. By the time you are over 60, there is almost always more than one road: medication, physical therapy, injections, watchful waiting, a less invasive version of the same procedure. If none of those came up, it is not because they do not exist. The third red flag: the option of doing nothing for now is never discussed. Watchful waiting, monitoring carefully and treating conservatively, is a legitimate medical choice. And for many conditions in older adults, it is the right one. If your surgeon cannot or will not tell you what happens if you simply wait and monitor, you do not yet have enough information to consent to anything. The fourth red flag is how your questions land. You ask something direct. What is your complication rate? What are my alternatives? What happens if I wait? And instead of a clear answer, you get a brush off. A confident surgeon does not get defensive when you ask the same questions they would ask for their own family. If the questions create tension in the room, pay attention to that tension. And the fifth red flag is a recovery that gets glossed over. Oh, you will be back on your feet in no time. That is not a recovery plan. That is reassurance designed to move the paperwork forward. An honest recovery description sounds different. It sounds like, here's what week 1 looks like. Here's when you will need help at home. Here's the part that is genuinely hard. Here's what to watch for. Specificity is respect. Cheerful vagueness is a sign that someone is managing your feelings instead of informing your decision. None of this means your surgeon is a bad person. The overwhelming majority of surgeons went into medicine to help. They work extraordinarily hard, but the system they operate inside is built around doing procedures. It rewards doing procedures, and it runs on 10-minute appointments where there is no time to walk through every alternative. So the bias toward action is almost never personal. It is structural. And the only thing that reliably cuts through a structural bias is an informed patient asking questions out loud. Now, one last thing, and it might be the most practical thing I say today. Never go to a major surgical consultation alone. Bring someone with you, a spouse, an adult child, a trusted friend. Here is why this matters more than most people realize. In many years of practice, I have watched it happen over and over. The moment a patient hears a frightening word, cancer, surgery, blockage, a kind of fog comes down. The mind goes immediately to the worst place, and from that moment forward, they barely hear another word in the room. Afterward in the car, they cannot recall half of what was discussed. This has nothing to do with intelligence. It is simply what fear does to the human brain. So bring a second set of ears. Someone calm. Someone who is not the one receiving the news. Who can actually listen. Have them take notes. Ask them in advance to write down the 4 questions, so that if fog comes down for you, they can ask on your behalf. A frightened patient and a clear-headed advocate together make far better decisions than either one makes alone. Do not walk into the biggest medical decision of your life by yourself. Let me bring everything together. 5 surgeries with serious hidden risks for patients over 60. Open heart surgery in frail patients, where less invasive options now exist. Aggressive spinal fusion, where the evidence for pain relief is far weaker than most patients are told. Major cancer surgery in patients whose bodies cannot survive the recovery. Elective joint replacement in patients with multiple serious conditions, where timing and preparation matter as much as the procedure itself. And emergency abdominal surgery, where the best protection is catching symptoms early and having honest conversations with your family now. None of this means avoid surgery. Surgery saves lives every single day. I have been part of that. I am proud of it. The message is this: be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion, and if necessary, a third. Your age is not your weakness. Your questions are your greatest strength. A surgical recommendation is not a verdict. It is the beginning of a conversation. And that conversation, made with full information and clear eyes, is the most powerful tool in medicine. More powerful than any operation I have ever performed. Type "I finished" in the comments if you stayed with me all the way through, and share this with one person today, not tomorrow. One person, a parent, a spouse, a friend who has a surgical decision coming up. Your share might be the most important thing you do today. Do not let anyone tell you it is too late, because it is not. And next week, I am revealing something that surprises even most medical professionals. A common recovery practice that most hospitals recommend, that research now shows actually slows healing in patients over 65. The data comes from a study that followed over 3,000 surgical patients and found one specific postoperative habit, associated with significantly longer hospital stays and higher complication rates. That is next week. You do not want to miss it. Take care of yourselves. Your health is worth fighting for, and I will see you in the next one.